Hello, everyone. Good evening. This is Dr. Khan. I'm going to go ahead and get started with the Facebook Live. A warm welcome to all the new members who are joining us on basically our Facebook private breast implant illness support group page, and also with other social media outlets such as YouTube. Hopefully you find this discussion informative. And as you will see, we'll get into a lot of detail and a lot of hard facts about what is explant surgery. And as you will see, we have a lot of information to discuss, a lot of information to share, and I will go ahead and get started. So having said this, a little bit about myself, I am Dr. Shaher Khan. I'm a board-certified general surgeon with 5 years of training. Following that, I did burns critical care, 1 year fellowship, and another 1 year of research. So that was 2 years, and then 3 years of plastic surgery training, and I'm certified, board certified by the American Society of Plastic Surgeons, a total of 10 years after medical school. And as you will see, my practice is now exclusively devoted to explant surgery, where basically I remove not only saline implants, but also silicone implants, and also residual capsules where other surgeons left behind. And the task and the challenge, as you will see, is to remove all residual capsule in those select patients where the complete total capsulectomy was not performed. As you will see, initially this may be relatively overwhelming, a lot of information, but as you will see, if you listen 10 minutes here, 20 minutes here, hopefully at the end of this discussion, you will get a good, firm idea as to what is explant surgery and what are the expectations. So having said this, the goal and gist of the whole surgery is to remove the entire implant, the entire capsule, the entirety of all inflamed tissue, where in majority of the cases where the implant is placed below the muscle, to remove the entire implant capsule as one system, which is the en bloc technique. The en bloc is basically where the entire capsule is removed as one system without a break in the capsule itself, such that whatever the internal contents of that capsule implant system is basically protected, and there is no spillage into the outside. And this is especially very important in the many cases where you have silicone implants. If it's ruptured, we don't want the silicone to spill into the periphery. And even in the case, for example, where you have fluid around the implant and within the capsule all contained, we don't want this fluid to spill into the periphery. And God forbid if this is lymphoma or if this is tissue that is full of bacteria, we don't want this to spill into the chest and cause a potential catastrophe that may not be contained or that may not be fully recoverable. For example, if the silicone spills into the chest, then no matter how hard one tries, the silicone cannot be completely removed. For example, if you can imagine slime that spills into the chest, no matter how hard the surgeon tries, for how long, the 2-3 weeks, the drains stay in place, or how much washout that the surgeon does, no matter what, this silicone burden will not be removed completely and definitively. So the whole challenge and essence of the surgery is that the surgeon must think completely, definitively, convincingly that all implants are ruptured, and that every care should be taken in order to completely remove the entire implant capsule and all inflamed tissue as one piece, as one system, without a break in the capsule in the en bloc fashion. Now, the en bloc cannot be done even by me 100% of the time. So in that case, 100% total capsulectomy, then that is mandatory, where the complete total capsule is removed and that no capsular burden is left behind, no matter how thin the capsule is. As you have seen in the many Facebook Lives that I have done, the capsule is so thin you can actually see it. It's transparent, and it's actually saran wrap thin. But it must be removed because that is the total heart and gist of the surgery. Anyone can remove the implant, but to remove the capsule, that is a burden, that's a challenge that cannot be done by the plastic surgeons. From my experience, from the many surgeons that I have talked to, and I recommend that you at least talk to the many plastic surgeons, at least 2 or 3 before you make a decision, you want to go ahead and ask that the surgeon how committed or devoted is he to removing the whole capsule. And as you will see, if you talk to 100 plastic surgeons, 90 of them will not want to even hear the word breast implant illness, and they basically state that the breast implant illness essentially is a myth, which is absolutely incorrect. And of the 190 of them would not want to even consider. Of the 10, for example, they will attempt to cauterize, incompletely remove, maybe leave the capsule behind, which is wrong, because the entire capsule must be sincerely, completely, definitively removed, and no capsular burden must be left behind. And it is very defined that the surgeon must be convinced in his or her mind that the entire capsule must be removed along with the implant, and all inflamed tissue must be removed completely, sincerely, and that the entire capsule must then be tested for the BII ALCL, which is the breast implant associated anaplastic large cell lymphoma, and that CD30 analysis should be done. Squamous cell cancer must be ruled out. Breast cancer must be ruled out, and any other abnormality or pathology must be ruled out. If there is any fluid around the capsule, as we saw a couple of weeks ago, that must be completely, sincerely removed and sent to cytology for CD30 analysis, because any fluid around the breast implant is BII ALCL till proven otherwise. One cannot tell by looking at the capsule grossly that this is cancer or not. Only the pathologist who is trained will, with the proper staining, be able to conclude definitively if this is indeed cancer, lymphoma, or whatever badness that might be present, such as multinucleated giant cells or histiocytes. And remember, this is the gist and heart and the whole soul of the surgery, where the entire capsule must be sincerely removed. And in this fashion, where vast majority of the implants are placed below the muscle, which is the pectoralis major muscle, the entire capsular burden must be removed. Now, in these patients where the implant is below the muscle, there's really no tissue below the pectoralis major other than the pectoralis minor, which is a small, thin cusp of muscle that's under the pectoralis major, and then you got the ribs. So in my surgeries, as you will see, and I dedicate on average 4 hours for every surgery, and I will say probably 2/3 of the time I run over the 4 hours. You will see when I do remove the implant and the capsule and the inflamed tissue below the muscle, I incorporate the fascia of the intercostal muscle, the periosteum, perichondrium, the fascia of the serratus anterior, and also the pectoralis minor. This is the bed or the floor directly on top of the rib, and underneath the pectoralis major, all of that fascia at the underlying aspect of the pectoralis major is removed, such that no capsular burden is left behind from what is a horizontal incision and not a vertical one. I do not want to violate the breast tissue. I do not want to cut into the glandular tissue of the breast, and that in itself will cut through the nerves, ducts, and glands and cause to other problems. Sometimes post-operatively, some patients will feel irregular masses if that does arise. And you will see the vast majority of the other surgeons actually make a cut around the nipple areola and straight down, or a J cut, which certainly causes a scar and also cuts into and around the nerves and ducts of the nipple areola complex. So that is basically a horizontal incision that I do, and I'm not a big fan of the vertical incision that cuts into the breast tissue and the nipple areola skin and those sensitive structures, because that only complicates and causes more problems rather than the goal of the surgery not being met, where, if you will, and I tell my patients, if you can imagine, this is the anatomy. You got the nipple areola complex at the top, you got the breast tissue, and then you got the muscle, and then underneath, which is the implant, and then you got the ribs. I'm always below the muscle, if you will, which is the P2 level, and P1 level is basically above the muscle, which I don't touch, which is where the breast tissue and the nipple areola is. And so I remove whatever is below in the P2 level without touching the P1, and so I do not want to distort or hurt the regular glandular tissue or cause more problems. And as you will see, most of the patients with the excess skin that I remove, with the which is our horizontal shaped skin at the bottom, and then which is in the crease, along with the breast tissue and the skin recoiling, along with the fluffing effect, and also the 10, 15, 20% muscle mass that the patient adds to the chest when they do work out, anywhere from 3 to 6 months, you will see that certainly adds overall to the aesthetics of the breast tissue, where the need for the unnecessary lift is not there. And as you will see, 80% of the patients in my practice basically do not end up needing a lift. They're actually very happy, and they are very content with the aesthetic appearance of the breast tissue. Now, a few things that I want to mention is fat grafting is a big no-no. It is what I would call malpractice. This past week, I saw a patient. She actually went to one of a very good, notable, board-certified plastic surgeon. She ended up having breast cancer on one side, and on the other side, she ended up getting fat grafting after what is a nipple-sparing mastectomy, which is absolutely what I would say wrong, because now she had fat necrosis. And the concern was by the surgical oncologist, if this is recurrent breast cancer or new breast cancer on the contralateral side, or if this is a mass that absolutely needs biopsy. So she ended up getting a biopsy, and they were only able to biopsy one of the two masses. And it turned out to be that one of the two masses was what is fat necrosis. And this is where the patient certainly was done disservice, and it's wrong to do fat grafting on the breast. We remember 1 out of 8 or 9 women are going to get breast cancer. You see the many patients who have had fat grafting who are actually very unhappy with the irregularities on the breast tissue. They're unhappy with the nerve/neurosensory changes, pins and needle changes, the irregular masses that they feel on their self-monthly breast exams. Sometimes they feel, they see this on the mammograms where there are masses that light up, which are fat necrosis, nodules that form and that are seen at the mammogram, and that lead to unnecessary biopsies. Fat grafting to the face, a very smart, very good idea, where 30% of the fat dies. On the breast tissue where the blood supply is not the best, at least 30 to 50% of the fat is going to inevitably die, and then leave clumps of dead fat inevitably, and will then cause and promote undue anxiety where unnecessary workup will be done. Now, the one thing that I want to mention here is, another patient that I talked to today, for example, she already had her explant done, and she now continues to have the many signs, symptoms of breast implant illness. Now, one thing where the patient stated, and I saw the operative note today from the surgeon who removed the implants, that the surgeon stated that the capsulectomy was performed. Now, I saw another operative report from another patient who was 10 weeks out from her surgery. I will tell you, when I saw that operative report, there was no mention in that operative report that the surgeon had done a capsulectomy, a complete, total capsulectomy. We also heard from the patient that came to me from England, and her surgeon stated that he had done a total capsulectomy, and on the same line he wrote down with his own handwriting that he left the capsule at the posterior aspect behind, which is total contradicts the initial first part of the sentence where he did a total. Total means complete, and then he stated that he left the capsule behind. So I was very much surprised that the surgeon who talked to the patient and the surgeon had an understanding that the complete capsulectomy will be done. That means 100% total capsulectomy, and the surgeon just wrote down capsulectomy, or in this other patient's case, where the capsulectomy, capsule removal was not even mentioned in the operative report. So I want all of the patients to directly be talking to their surgeons, not to their nurse practitioners, not to their PA or to the residents or the fellows. You want to have a bond directly with your plastic surgeon so that you are at peace and you have that confidence of your plastic surgeon who will clearly, outright be telling you convincingly that he or she is going to completely remove the capsule. It should be part of the consent that states that the goal of the operation is 100% total capsulectomy, preferably in en bloc fashion. If the en bloc cannot be accomplished, a total capsulectomy must be done. Number 2, your surgeon must be taking high-definition videos of the chest showing complete removal of the capsule and cutting open of the capsules. Your surgeon must also have a track record of doing en blocs and complete total capsulectomies and totally being 100% transparent that he or she has done a total capsulectomy. And there should have a platform where, if you will see my private breast implant illness support group page, all my previous patients are talking to the prospective patients, and I'll tell you, there is no such Facebook group that exists with any of the other surgeons, unfortunately. And I find, if someone wants to get a gallbladder out, it is understandable. There is technically only one way of doing it, or two ways. When it comes to explantation, if you talk to 10 different plastic surgeons, you're going to get, unfortunately, 10 different answers. Some surgeons want to rupture the saline implant. That's an absolute no. Some surgeons want to leave part of the capsule behind and cauterize the capsule on top of the rib. That's absolutely no. Then you're going to end up like this patient who had her surgery done in April of 2023, and she continues to be in misery and pain with all the symptoms of breast implant illness, and she's in this post-operative phase where she continues to hurt as if she had no explantation done, even though her surgeon states clearly that the capsule was removed. Ideally, another quality your surgeon must have is your surgeon should not be putting in implants. In today's world and age, in 2023, there is ample direct evidence, number one, by the FDA, which has clearly stated that, number one, that the breast implants are not meant to be in the body forever, both saline and silicone. Number 2, the breast implants are associated with BII-LCL, CD30 and BII-LCL, and that some patients have actually died, and it is underreported. And the FDA also has acknowledged the fact that some patients develop confusion, some autoimmune diseases, connective tissue disorders, and basically, once the implant is removed completely, these patients develop, or these patients have, quote, complete resolution. That's the word, complete resolution, that the FDA used, so that they acknowledge that the BII, breast implant illness, indeed does exist, and that there is complete resolution. If you listen to what the manufacturers are saying, so that's the second group of people, or the manufacturers themselves, be it Mentor or Allergan, you will see they themselves tell you you should get an MRI at year 3, and then every 2 years they're onward. They tell you about the many detrimental effects, which they also highlight the FDA warning, those 3 points that I mentioned earlier about the implants not being there in the body forever. They are not lifetime devices. Number 2, the BII-LCL, and then the BII symptoms. They also mention that the implants should not be inserted in patients who have autoimmune diseases, or who are immune compromised, who have depression, patients who are actively nursing, or who plan on getting pregnant. They should not be getting implants, quote unquote. And I want you to see this at the back of the Mentor magazine itself, say, for example, our journal. And you can see all of this, which I discuss on my private breast implant illness support group. And the last thing I want to mention here is you look at and just see the many patients who have explanted and who have sought benefit of explantation and have basically removed the silicone toxicity, both with silicone implants and saline, and they have basically freed their body of the toxins and the many signs and symptoms of breast implant illness. And you will see the many before and after pictures, not only the patients themselves, but the celebrities. 5 years ago, not many people were talking about breast implant illness. Now you have a lot of celebrities and patients, and essentially it's a social media phenomenon. And hopefully this is what's going to hopefully cause the change that the FDA is looking for, and ultimately lead to a second and permanent ban, not only of silicone implants, but also the saline implants as well, which are certainly equally worse. The patients that present with saline implants have the same set of problems that patients with silicone implants have, and certainly the same set of problems that patients with ruptured silicone implants have. So again, choosing your surgeon is a very critical aspect. You should actually tell your surgeon, do not remove the capsules, which I have had some patients, and your surgeon should outright say, absolutely, I am going to remove the capsule. That's your surgeon. Your surgeon should be very vocal and open. I had a patient that went to a plastic surgeon who said breast implant illness does not exist. That surgeon is not going to do the surgery you're looking for. If you have a board-certified plastic surgeon, and if you go to the top 100 hospitals in the country, you will see all of them will inevitably replace the implants that you have if they're more than 10 years old, but no one will talk about doing what is a total capsulectomy. Now, if you think about it, one of my plastic surgery colleagues, he mentioned, what you're doing is not the norm. It is out of the ordinary. And, one day, whatever you're seeing and doing will come back and haunt you because you're basically doing the Facebook Lives such as this, or directly from the operating room. And I will tell them, and I told him, just look at the two facts. All what I'm doing is I'm just removing the implant, and I'm guaranteeing removal of the whole capsule, which is the heart and gist of the whole surgery. And in those patients that have lymphoma, it is mandatory, it is required by the plastic surgery principles that the entire capsule must be absolutely be removed and CD30 analysis be done. And if you don't want to come back and then remove the capsule, upon finding out if this is the BII-LCL. And so that is what I'm doing. And number two, I'm doing it very safely, and I'm doing it very transparently. And most importantly, if you see the patients, how they're benefiting, and they are very happy with the results because they have freed their body of the many signs and symptoms of breast implant illness. So I just want to go ahead and emphasize, I want each and every one of you to look into your surgeon's op notes from the previous patients so that you can get an exact, firm understanding as to how your surgeon has done the plastic surgery procedure, specifically explantation, where he or she is not only removing the implant, but removing the implant and the capsule and all inflamed tissue in the manner where the fascia of the intercostal, the pectoralis minor, the periosteum, perichondrium, and the fascia of the serratus anterior is removed. Now, one question that I have been asked lately, well, you're removing the fascia. I will tell you, in the world of plastic surgery, look, we do reconstruct noses, for example. We take rib. We cut rib, and we cut the cartilage off of the rib and reconstruct the nose. We cut, for example, the palmaris longus tendon right here in the distal forearm and use that as a spare part to reconstruct tendons. And removal of the fascia is a very typical standardized way of doing surgery. For example, if someone gets a tummy tuck, you look at all that relative, the dissection that's done all the way in the avascular plane, or someone who has a broken femur, or let's say a metacarpal bone in the hand, the surgeon has to remove the periosteal layer directly on top of the bone by a periosteal elevator, which basically means that you denude that layer of tissue directly on top of the bone in order to put the plate and screws. So this is very typical and standard. At the end of the day, the take-home message is no capsular burden must be left behind. And all one needs to look at is two facts. Look at the many patients who got their explantation and only the implant was removed and part of the capsule, or part of the capsule was removed. And only when did this patient go back and get a residual capsule removed, only then did she bounce back to a good normal state of good health minus these toxins. And so this, again, is proof that the whole capsule must be removed. And number two, you look at the many pathology reports where the capsule is analyzed, and you will see the breast implant particles, silica, giant cell reaction, histiocytes, foamy macrophages. These are all the inflammatory cells that are present within that capsule that absolutely must be removed in order to bring, quote, freedom from the many signs and symptoms of breast implant illness. What I'm going to do next is I'm going to go ahead and answer some questions. Please feel free to go through my YouTube page. You can go to my web page as well, where you have all the links you're looking for. You can certainly join my private breast implant illness support group page. You'll get a lot of information. You know, what's interesting is, like I said earlier, if you talk to 10 different plastic surgeons, you're going to get 10 different answers. Your plastic surgeon, ideally, as I mentioned earlier, should and must not be putting in implants in the world and age that we live in today. So what I'm going to do next is I'm going to go ahead and answer any of the questions that you may have, and I'll go ahead and get started with that. I have had a lot of questions over the several weeks, and hopefully I'm able to answer each one of them, and I'll do my best. So the first question that I'm looking at is, is it possible that breast implants can cause uveitis of the eyes? Now, one thing we know of for a fact, I want you to go to my private breast implant illness support group page and type in MD Anderson, which is a paper out of MD Anderson by Dr. Clemens, where they looked at 100,000 patients. And they looked at studies, 80,000 of patients that had silicone implants, 20,000 that had saline implants. And they concluded that patients who had breast implants had a very high likelihood of getting Sjogren's, which is dryness of the eyes. Now remember, breast implant illness is inflammation that is present anywhere from literally the top, from the hair follicles all the way down to the plantar fasciitis, which is the soles of the feet. So briefly, migraine headaches, rashes on the face and the chest, very typical standard, dryness of the eyes, periorbital edema. You look at the patient's face and they look sick. You see the swelling on the face, the red rashes, for example. You see patients have tinnitus, ringing in the ears. They have vertigo. They have the throat trickle, swallowing problems. They have like throat irritation, lymph nodes in the neck that light up. They have migraine headaches. Their psyche is affected, the depression, anxiety, suicidal ideations. Now, these are not my words. These are the words of the patients themselves. This is very conclusively proven. Neck and back pain, fibromyalgia type symptoms, chest problems, breathing irregularities, ground glass opacities on the CT scan, irregular heartbeats. You have patients with thyroid problems that occur, autoimmune issues, adrenal issues. You have GI disturbances. They have reactions to foods, for example. They have irregular arrhythmias, heartbeats, where they have worn Holter monitors, panic attacks that give the illusion that there's a heart issue. You have patients with rheumatological joint problems, which are the hallmark features. And then you have all the other problems like tingling numbness in the legs and hands and feet, cold discolored hands, Raynaud's phenomenon, and certainly all inflamed tissue, including uveitis, irritation of the eye, that can be present. That is basically the features. And so I tell my patients, if you go to my website, you will automatically be directed towards a questionnaire where you have the 55 signs, symptoms. The most common being fatigue. Someone sleeps 8-10 hours. They still could sleep another 4. They don't have the energy. They take naps in the afternoon and they still don't feel re-energized after a long nap. So these are the patients who continue to hurt. So anything itis, uveitis, arthritis, conjunctivitis, dermatitis, anything itis, inflammation can occur as a result of the implants. Some more, some less, some not at all. For example, some patients develop UTIs or cystitis, irritation of the bladder. Some patients get arrhythmias. Some patients get blood pressure. And again, these are the words of the many patients who have come off blood pressure medications. Some patients who have had a full cardiac workup and the doctor is telling the patient, you don't have any cardiac issues, the 35-year-old nurse, for example, and you need to go see a psychiatrist because you're just too stressed out. And unfortunately, this is what keeps happening, that the patients get the complete workup. There is no lab test, there is no imaging modality, and the patients unfortunately get diverted towards a psych, and they feel that they are, quote, stressed out because of, social media anxiety amongst others. But the implants, unfortunately, God forbid, don't say anything bad to them. The general notion is the primary care doctor thinks the implants are safe, and now everyone else thinks the implants are safe. If you talk to any doctor, you will see they will point the finger at everything except for the implants. And I'll tell you, if you ask me about diabetes management or blood pressure, I will tell you I do not know. And likewise, I wouldn't expect a primary care doctor to comment on breast implants because they have probably not even touched an implant in their life. So it's an area that they don't have, with all due professionalism, they don't have the expertise, and a primary care doctor thus cannot comment about the safety profile. All one needs to do is just accept the fact that the implants in 1992 were banned, and the same set of problems with saline implants occurred, and the patients, when explanted with the entire implant plus the capsule removed, you see the before after on social media and the freedom from the silicone toxicity. So how are you able to avoid drains in most cases in your explant surgeries? Is it the way you cauterize tissue and blood vessels? So I will tell you, if you have any nurse or any surgical tech or assist, they will tell you, just like you have a good lawyer and a smarter lawyer, you have a good driver and even a better, smarter driver. Inside the operating room, it is a very meticulous surgery. Now, I will tell you, initially when I started, I did all aspects of plastic surgery. Plastic surgery has 3,000 operations. And I did a lot of hand, face, skin cancer, hand reconstruction, burns. Remember, 1/4 of the plastic surgery exam in itself is hand surgery. And hand surgery is a lot more trickier than plastic surgery. So the point here is that whenever I did the hands, I did the face, I did a big flap, for example, with squamous cell cancer, my blood loss was always minimal because I was always taking my time, no rush. There was no block or deadline. Whenever I do operate ever, from the beginning of time, I operate as this is my only patient. And as you will see, if you go to any of my YouTube videos, my blood loss in well over 99.7%, if not more of the patients, the blood loss is 5 cc's or less. And I'm in that avascular plane, the bloodless plane. And I'm dissecting very carefully, very meticulously, where the blood loss is 3 cc's, 5 cc's in well over 99.7, 99.8% of the patients. And so, as you will see, barely the lap sponges have more of the local anesthetic that I give that basically leaks out. And I don't like to cauterize the skin area much. So the point here is just look at any of my videos. And I've given my videos, the patients themselves, I give their videos to them and over hundreds. And, the point I'm trying to make here is I take my time to dissect. I am in that avascular plane, in that bloodless plane. I don't let any silica spill into the chest. I remove all of that capsular burden. I don't let any of the silica spill into the chest in the many, many, many explants that I have done, to the point where the last time I used a drain period was well over 4 years ago. And I want to go ahead and state I presented my data at the plastic surgery conference in Dubai, where we had the largest group of plastic surgeons from all over the world that merged together in one roof. We actually created what is the Guinness Book of World Records, and I presented my 1,000 explants that I have done and showed pictures to them. And these are, remember, board-certified plastic surgeons who have augmented 20, 30 years of their life, and these are the world's best plastic surgeons who have written textbooks. They give lectures all over the world from each and every respective country that was present. And this is where I shared my data, and I was very happy to share the data. And remember, I had a lot of critique by the many surgeons who questioned why I would challenge them. And again, I've put forth, and hopefully in the next couple of months, I hope to present the same lecture plus addendum slides so that I can teach the patients, and in a different format such as the Facebook Live, so that I can show how I'm doing it, why I'm doing it. Now, the burden is not on me to show that why I'm not using drains. The burden is on all those other surgeons, very professionally and very respectfully, as to why they are using drains, because I have a whole track record of putting no drains in my patients. Now, the moment the silica spills into the chest, the silicone spills in the chest, the residual capsule is left behind, or the surgery is done in a very, I use the word non-sophisticated, dedicated way, where there is a cut into the muscle, or the capsule is left behind, or there is non-precise usage of the cautery, then the indication or the use of the drain becomes mandatory. So the burden's on them. Why are they using drains? Because I have a track record of doing the surgery safely without using the drains. And this is where not only is the bloodless plane that is utilized less blood loss, there is less trauma to the tissues, there is preservation of aesthetics, and there is less trauma, less pain. You will see 2/3 of my patients don't require much of pain meds, maybe for 2-3 days, Tylenol, Motrin, if at all, and maybe Tramadol, but 1/3 of the patients do require some pain meds, and sometimes these patients have other issues where they might be dependent on some narcotics, or they might have used pain meds, or their surgery just might be relatively very involved, where the 800cc implant was sitting on 6-7 ribs, and that is a lot more tedious, very much involved surgery. And, pain medications are certainly very much required in those patients, just like someone after a hip implant would require pain meds. Do you see more BII symptoms above or under the muscle? Now, I will tell you, my ideal patient is this. My ideal patient is the patient who has the implants above. Now, going back to the question specifically, do you see more BII symptoms above or under the muscle? I'll tell you, no matter what, where the implant is, it causes the same reaction. So I cannot gauge and tell if a patient has an implant above that her symptoms are going to be less. You will have the same set of problems if you have saline implants, silicone implants, ruptured silicone, or even residual capsules. And don't listen to me, listen to the many patients who have residual capsules. They feel like they didn't even benefit from removal of the implant. So you will get the same set of problems regardless of where the implant is. If you take the same implant and let's say put it on the thigh, the patient will exhibit the same set of problems, because remember, the silicone is leaching. It's going to go into the periphery and cause that foreign body reaction that we know of as breast implant illness, and continue to hurt the patient and cause the body to mount this reaction, and hence be in this consumptive state where it is being taxed by this overburdened immune system. Which one is easier to take, implants above or under? Without a doubt, the implants above the muscle are relatively easier because the dissection is not done. Now, having said this, if you ask my assistant, he still dreads that one case that we did where the implant was above the muscle, and it was extremely challenging, and believe it or not, it took almost 2.5 hours just to do the one side. And so I would rather operate on an implant above any time of the day versus below. Below, you're directly on top of the rib, which certainly does make the operation very, very hard. One of my patients was telling me, and some of the surgeons, you will see they actually developed a consensus in Canada where the group of plastic surgeons got together and concluded that explantation should not be done by capsulectomy given the inherent risks of the problems and the challenges of the surgery. That is indeed true. And like I said earlier, if you go to 100 plastic surgeons, 90 of them will flat out not even want to do an explant with removal of the capsule. And of the 10, 9 out of 10, if not all 10, will attempt to remove. But this is where the surgical expertise and the determination comes into play. This is also very important. your surgeon should, and I feel, and I say this from my experience, not everyone can do the surgery from a physical perspective as far as the physical demand of the surgery in itself, plus the concentration, plus the surgical technique and skill, plus that confidence that the surgeon needs to have that the whole capsule must go. Because if I didn't believe in it, I would be putting in implants, another way to look at it. And the other important thing here is, if I did not believe that that whole capsule must be removed, I would not unnecessarily overburden myself by doing these surgeries that are extremely challenging. And I say it is not easy surgery. Otherwise, everyone else would be doing it. And so you will hear the many surgeons say that is not safe, I don't want to do something, or they will attempt to, out of good heart, enter the operating room with a sincere effort to removal of the capsule. But when the going gets tough inside the operating room, they will back off and say, for the betterment of the patient, I'm not going to do this. And I find if your surgeon feels uncomfortable putting in a chest tube, he or she will shy away from doing a complete total capsulectomy because they have to feel comfortable around and about the chest. And I will say this, I've taken care of patients with gunshot wound to the chest, putting in chest tubes, rib reconstruction, radiation, bone necrosis of the ribs, where reconstruction and flaps are done in order to reconstruct. One has to be very proficient with that in order to do the surgery so that they can have that confidence where they can remove the capsule completely off of the rib with comfort because they know they have done much worse, if that helps understand, translate to as to how the surgeons think. My ideal patient is someone who is postmenopausal. Remember, the older one gets, the tissues get easier to dissect. Someone who is 35 has more robust, thick, beefy red muscle versus someone who is 65 who is thin, attenuated, more like gray, pinkish muscle, which is much easier to dissect. And the tissues certainly are easily dissectable. The breast tissue is not as, in those cases where the implant is above the muscle, the breast tissue is not as firm. It is essentially being replaced by fatty tissue, so the dissection certainly becomes easier. And remember, my goal is not to touch the breast tissue at all. I'm always directly above the muscle in those patients where the implant is above the muscle, and in majority of the cases, well over 90%, 95%, where the implant is below, I'm always below the muscle in that P2 level because I don't want to touch the breast tissue and cause more problems and irritation. Can you please explain the reasons for the binder? So I will tell you, if there is one complaint, just like this one nice patient today where I did a flat chest reconstruction after her bilateral mastectomy, the single biggest complaint in my practice is the binder. Now I will tell you, when the patients undergo a tummy tuck, they have to wear that nice garment that goes to their mid-thigh all the way up to their chest. When someone gets a thigh lift, they get double A straps or they get a special compression garment that they wear all the way from below the knee all the way up into their abdomen so that they can apply compression. This is Principles 101. If someone, like a male, gets a gynecomastia surgery where they have the male breast tissue is removed and the glandular tissue is removed and the fatty tissue is removed, they have to wear that garment for 6 weeks. So this is 101, Principles of Plastic Surgery. The first day they teach you this. So this is, you go to, for example, Marina, M-A-R-E-N-A garments. There are companies, this is the best company that devotes their entire company to preparing compression garments for patients. So after the explant surgery, you can imagine there is a big void where the implant was sitting. And remember, whenever I remove the implant, there's 3 volumes that are removed. The volume of the implant itself, the volume of the capsule. Sometimes the capsule can be very thick, maybe a half a centimeter, or maybe 2 centimeters thick that one time that I removed. The volume of the implant, the volume of the capsule, and then also the inflamed tissue, the green dilated veins that occur as a direct result of that inflammation. So once that is removed, you want to be able to allow compression that not only holds the chest together, but actually kind of gives like a recoil as well, so that when you twist and turn in bed or get in and out of the car, there is no point up and down movement of the breast tissue. And so that becomes, again, critical for the 6 weeks. After 3 weeks, in a good number of the patients, I have them remove the binder at night, because when they're lying down, there is no gravitational force. And so for the first 3 weeks, maybe 4 weeks, depending on the BMI patient, depending on the size of the implant, if someone has an 800cc implant, I will have them wear longer. Remember, I call the shots from start to finish. I talk to my patients. There are so many patients, hundreds and hundreds, even the many other patients that I did who were non-explant. I spend the time with them pre-op, post-op. I give my phone number because I want to follow these patients very closely post-operatively. And I only know what happened in the OR, not my nurse, not my PA, not my circulator, not my assist, and I can direct them depending on their progression. Remember, the breast tissue itself is inflamed. It's unhealthy. So you have a patient who gets a tummy tuck, that's good, healthy tissue. It's not inflamed. It's the patient's tissue. These patients with implants, they have inflamed tissue. You can see, just look at the pathology. So this tissue is not healthy. And this is inflamed tissue, irritated tissue. And remember, the whole goal is to remove that inflammation, that burden, the capsule, the implant, plus anything in the periphery, such as fat necrosis. As you will see, look at the many pathology reports. I have removed fat necrosis, fibroadenomas, masses, lipomas. I have removed from within the patients underneath. These were abnormal masses because they look abnormal, they feel abnormal, and they don't belong in the chest, so I removed them so that there is no inflammatory burden left behind. So when the patients have the bra and binder, this gives them that recoil, it gives them the support, also helps with the pain and helps with the aesthetics recovery. And again, one of the principles of what is explant surgery. Even if the patient has a tummy tuck and they have 2 drains, I still put in, and remember, any plastic surgeon who does a tummy tuck must 100% of the time put the whole tummy tuck garment that goes up to the mid-thighs. Likewise, after explant, the bra and binder is key. It's a necessary evil. It is very much required, absolutely, for optimal healing. So the next question here is, I am really in a quandary, now 76 years old. I have had a silicone implant since 87. That is reconstructed breast falling and mastectomy. I have no issues with the implant except that in 2019 I was diagnosed with primary biliary cholangitis, which is a liver problem. IBS became part of my daily life as well. A series of the abdominal MRIs revealed ruptured implant. Blood work is fine. Many doctors do not recommend explant. I fear that surgery of this magnitude would be too risky. Now, I will say this to you. I've operated on 75-year-old. These are, again, all my Facebook Live cases, Facebook cases that I've discussed and shared with. The oldest patient I've operated on is 81. Now, I want my patients. So this is another very important point. I have patients, 2/3 of which basically come to me from out of state, from California to New York, Texas, Florida. These are the 4 most common states, and then all over. Idaho, Washington State, Nebraska, West Virginia. Just today I talked to a lady from California. Last night I talked to a lady from California as well. And as you will see, I had a patient I took care of from England last week. I talked to a patient 3 weeks ago from New Zealand. I have patients from Germany, Japan, Dominican, Panama, and again, Canada, Mexico. And remember, a human being from Qatar that I operate on, she's still the same human being that is from the U.S. The point here is the implants are not safe devices. And you have an implant from what she was saying was 1987. Remember, the implants are not meant to be in the body forever. You can imagine if you look at silicone implants, saline implants, when they do rupture, they collapse completely like a water balloon. Silicone implants, when they do rupture, you may have a silent rupture. You may have a normal exam and everything looks unremarkable. That's why Mentor itself, for example, in the journal that we read every month that we get, it basically tells us you need to get an MRI at year 3 and then every 2 years there onward. And this is looking for a silent rupture because the exam in itself will be totally unremarkable. So just the fact that she has had a rupture for a long time, very likely, because that's going to be 13 years and then 23. So you're looking at 13, 23, 33, 34, 35, 36 years. And look at how many patients I've done where they have ruptured implants. Now, if this lady talks to me, and remember, I filter all my patients. I talk to all my patients. And I get a good feel as to what is the status of the liver and what is the status of the liver function test and the clearance from her hepatologist. And I get good feedback from her primary that she has no bleeding issues or clotting issues, because remember, liver is integral to a clotting of the blood. And she has good liver function and she's optimized and ready. I will tell you, she will certainly be a candidate. Remember, I have offered surgery at the hospital with patients with open heart surgery, patients who have a carotid that is completely clotted. I've operated on patients with a history of DVT and they're on blood thinners, and I bridged them with Lovenox, and I was able to operate in that window where it was safe. So on a lot of sick patients with history of seizures, for example. And so if I determine that she is safe and she's a candidate and what her symptoms of BII are, I will tell you, I will then make the decision that if and when we should proceed with surgery. Just today, I talked to a patient and she has implants. Her mom also has implants, and she is 83, and she had a pacemaker. I've already operated on patients with a pacemaker at the hospital, and patients with a lot of other. So I will determine if she is a safe candidate, and absolutely I have said no to a lot of patients because I don't want to do any surgery that may potentially end up hurting the patients. Because remember, any surgery can get relatively very involved, and just like any surgery, even a colonoscopy can get involved. And so I will then make a determination if it is safe and wise to proceed given the risk versus benefits, just like any surgical procedure. I talked to a patient yesterday. She's 47 and she gets her feeds through her jejunum, a tube that goes directly into her stomach. She has a port through which she gets IV medications. Now you can imagine she's 47, but she's very sick. So I said to her, I want to get a full medical history and basically exam. I want to see an evaluation by your doctor. What you're telling me is good. I want to go ahead and get that clearance and that reaffirmation from your doctor before we even consider proceeding forward, because I don't want to be involved with the surgery where, for example, she was nutritionally compromised and she did not heal, or another patient who's type 1 diabetic and she has a bad A1C of like 11. That's not an operative patient till she is able to better her numbers. There was a patient, if you go back to the Facebook Live, I talked to, this is another lady in her 40s. I talked to her, I got her liver function tests, and after talking to her, I told her, I'm not happy. I want you to go see a hepatologist. And lo and behold, and this is again all on Facebook, she went to her doctor, she got a workup, and it turned out that she had undiagnosed hepatitis C. So she got her hepatitis C, and this was just a discussion she and I were having. And remember, my discussions as an MD, I just don't look into and ask about, implants and we move on. I always inquire about the physiology, the basic health of the patient, and then make a determination. So this patient actually ended up getting diagnosed with hepatitis C, treated with hepatitis C, and then she came to me and got her explant done safely, wisely, and without any surprises. And this is, again, part of the workup. As you will see, there are times where I cancel the patient. There's another patient, for example, you probably have heard, she had a UTI, and then she ended up getting colitis, which is inflammation of the colon from a couple of doses of macrobid. Now, for me, I don't want to operate. Now, she was scheduled to get a scope. I want a clearance from a doctor. I want to make sure that when she comes to me and I prescribe her some antibiotics, there's going to be no surprises. Even though she's young, she's in the late 30s. I want to make sure that I myself have screened the patient, and there are going to be no surprises. There are some patients that come to me and say, I will sign that I take full responsibility. And I tell the patients, absolutely not. I am myself, it is my practice, and I want to be going into a surgery with the best foot forward, without any surprises for the patient, because it is my responsibility as a surgeon to proceed. If you ask me, personally speaking, the surgery is the easiest part of the whole process. There's an entire pre-op workup that is very serious, and again, I do it. This is the clearance. There is the intra-op, which is the day of the surgery and what happens inside the operating room, and then there is the post-op care. I will tell you, pre-op, intra-op, and post-op. The hardest part is the pre-op. Intra-op, I find, is relatively very easy. What happens inside the eye, again, like to operate. And what happens afterwards, if your intra-op and your pre-op is good, your post-op is always good. Now, there are always, basically inside the operating room, there are some surprises that always come and go. But again, this is where we have looked at all aspects of the patient so that there's no surprises, and the patient and I are at firm understanding about what is anticipated, what's the plan. If the thought even crosses my mind that the patient needs to be done at the hospital, I operate at the hospital because I do not like to take chances. Now, what I'm going to do is I'm going to go ahead and now I will tell you, breast implant illness is very much getting recognized. This one patient I talked to in the last day, she actually had her doctor from New York refer her to me as far as getting the capsules removed. These are the residual capsules, because she was not improving. And this is where you will see the doctors are slowly catching on, and they're starting to recognize that breast implant illness is a real entity. And the rheumatologist who recommended this other patient to come to me, and this other doctor in New York that made the recommendation for this patient to come see me, these are, again, very good, healthy signs that the medical community is slowly learning, and the patients are also teaching the doctors as well. And some doctors who are open-minded are certainly very much embracing what is truly an illness that is very much recognized by the FDA, by the manufacturers, and certainly by the patients that are bringing it to the attention of the vast majority. Now, what I'm going to do is I'm actually going to go ahead and go into the Facebook, and I'm going to answer some of the questions. And so next question is, for how long after explant surgery can one expect to experience pains in the breast tissue, and what causes these pains to come and go? Now remember, this is true after any surgery. Let's say if someone gets thyroid surgery or midline abdominal surgery, and certainly after this explant surgery, that the tissue is settling down. The sensation to the chest and breast tissue is certainly very much there. Now, sometimes when a surgeon cuts through the nipple areola to put the implant through the breast tissue underneath the muscle or above, you can only imagine the trauma that the surgeon does in order to dissect into those respective planes. Now, if you can imagine, once the implant is removed, remember, I'm making a horizontal incision, and I'm always below the muscle. In those patients where the implant is below the muscle, and in those patients where the implant is above, I'm directly above the muscle underneath the breast tissue. And this is where I'm able to operate on the many patients who are actively nursing, because I don't touch the breast tissue at all, and I'm operating in the zone below, and there is no spillage of that milk, the lactation, the ducts into the area underneath. And so for that reason, I'm able to operate very safely, completely, definitively. So I don't touch any of that unnecessary tissue. That's why I am in that respective avascular plane underneath the muscle. Now, when I do dissect, the tissue becomes essentially collapses and settles, and you can imagine sometimes some patients, you will hear directly from them they report that they had no sensation to begin with around the nipple areola to begin with, and very likely they will not because those ducts nerves were cut. And they tell you when you get an augmentation that certainly is one of the side effects. Some patients have hypersensation, and I tell the patients initially that's actually a good feeling. I tell my patients to massage at least for a 6-month period or 7-month period, and you will see when they massage, they stimulate the nerves to come towards the surface. They cause the nerves that went haywire to settle down. And then, as you will see, the scar tissue that's present takes 9 months to a year to settle, sometimes up to 18 months, depending on the patient. So those sensations are certainly very much balanced out and even out. And the patients, a vast majority of them have resolution of the pins and needles a year out. Now, I want you to also notice, and I want you to pay attention to the fact, if you look at my Facebook page, and I wish every single surgeon who explants allows for a Facebook medium, be it whatever it may be, so that the previous patients can talk to the prospective patients and there's complete transparency as to why and how they're doing the surgeries. And I want all the patients to go into and look at your surgeon's operative note so that you can read between the lines and confirm exactly what was done, not visual or verbal, but what was translated on the consent form, i.e. the bond that the patient has with the surgeon, and also that you yourself have seen post-operatively that complete 100% total capsulectomy was done or an en bloc was done and that no capsule was remaining behind. This is what I call the 100-100-0 rule. 100% of the time, 100% of the capsule is removed with 0% of the capsule remaining behind. I don't want you to fall into the trap, well, this doc came recommended. Nowadays, you pay someone and you basically get moved to the top of the list with an asterisk, and this list now is governed by someone who has no concept of medicine, no concept of surgery. All what their bond and bind is how much financial donations that the surgeon gave to that Facebook owner. I myself have received Instagram texts, private message group texts, emails stating that if you donate to my Facebook page, you will be bumped up and we will promote you. Unfortunately, that is the world we live in, where people are capitalizing on this and basically sending messages to these surgeons who are unfortunately hungry for patients. And this is, remember, the patient's job to pick and choose and feel comfortable with the surgeon that they are signing up for, because they have absolute 100% full faith and confidence. You don't want to be that patient who unfortunately post-op is thinking, even second guessing if the surgeon removed the whole capsule, because then that is a nightmare to deal with, that patient that I mentioned earlier. So I told her, I want to see the 5 signs that your surgeon did a good job. And again, it's important for me to discuss. Number 1, the length of the incision should be approximately the diameter of the implant. If your surgeon removed the entire implant from a 2-centimeter incision, you know that surgeon did not remove the whole capsule because you cannot visualize. Number 2, your surgeon must make a video, high definition of the chest, and also a cutting open of the capsule's video, and plus the pictures that clearly states that the entire capsule was removed completely, definitively. Number 3, your surgeon should return the implants. So in those cases, the saline implants were not ruptured. Number 4, your surgeon should very actively discuss on social media that he accepts what is breast implant illness, and that she talks about the detrimental nature of the implants and what is the purpose, that the whole capsule was completely definitively removed along with the implant, and that it was all tested for not only the BII, CL, CD30 analysis, but also cultures for aerobic, anaerobic, and fungal, and anything even remotely suspicious was also tested, so that post-op the patient has the peace of mind. And this is again the 5th point that is also very important. So this patient that I talked to today, she said her explant surgery for 425cc implant was done in 45 minutes. That automatically tells me that the surgeon did not do the en bloc. So the timing of the surgery, every patient that goes into the operating room, the surgeon is obligated and mandated by the medical communities and societies and medically legally, just like every plane that lands, they have to record the flight takeoff and landing. They have to record what time was the incision made and what time the surgery was over. And on average, I book my patients for 4 hours. And this is where I do 2 cases on average. And at most, I have done 3 cases per day. And this is essentially just the explant alone. This is no lift. And this is where you have the checks and balances, especially the fourth one being most important, where the reputation of the surgeon is tested. Now, myself, as you will see, I have my own way of doing it, the 100-100-0 rule. 100% of the time, 100% of the capsule is removed, with 0% of the capsule remaining behind. And the way I do it, as you will see, the con procedure, number 1, you have no drains. Number 2, no lift. Number 3, twilight sedation, where the patients are comfortable breathing on their own. To date, as you will see, not a single patient has had any recollection of the surgery, or they've woken up, or they have talked to anyone in the team, because they're completely amnestic to the whole event and their pain control is optimized. Number 4, the implants are always returned to the patient. Number 5, the capsules are always sent to pathology, rule out the BII, LCL, CD30 analysis, rule out lymphoma. Number 6, the cultures are done for aerobic, anaerobic, and fungal. And number 7, the videos, high definition videos are done of the chest wall, showing complete removal of the entire capsule, plus cutting open of the implant. And then the still pictures, high definition, showing that. And number 8, every patient, no matter what the comorbidities, no matter what the illnesses, be it young and healthy or elderly and sick, they get the same surgery where the entire implant capsule is removed and there is no compromise in the surgery because of the patient's age or health or other comorbidities that the patients may be on. So do your research. You're better off living with implants than doing one and then regretting and then going back to another surgeon, because any time of the day, I would rather do a implant capsule and inflamed tissue for the first time, without having had to go back in and removing residual capsules. Unfortunately, I find where the surgeons try to remove the capsules, they try to remove what is like a wet tissue paper. They leave some of the capsule behind, so it becomes more of a challenge and a burden for me to remove the residual capsules. So you're better off doing the surgery right and once the first time around, and to doing it in a definitive way. And remember, this is a surgery that easily can be done. I talked to a lady from North Dakota this week. She ended up retracting her phone consult, and again, God bless her soul, for whatever reasoning and thought process. I believe she wanted to be close to home. Now, I'll tell you, you have to have that full faith and confidence in your surgeon, because if you don't want to be in that miserable state where you're second-guessing your surgeon and your situation, and now you have to undergo the same surgery because you're not getting better. Now, what I'm going to do next is, let me go ahead and answer any more questions that you may have. Yes, so this is a nice question from my California patient, Dr. Khan. Is there still a risk for BII-LCL after explanting? So if someone has suspicion or a diagnosis of BII-LCL, a lymphoma, the textbooks, the plastic surgery community mandates, it becomes essential. It is malpractice to not remove the capsule. So it is important that your surgeon, if there is even a doubt, that the entire capsule must be removed. So this is textbook answer. If there is BII-LCL, 100% of the capsule and that fluid must be removed and tested, along with the implant must be removed. And if the capsule is left behind, the general convention by all 100% of the plastic surgeons is that all capsule must be removed. I'll say this one more time. If there is BII-LCL or fluid and there is BII-LCL, it is required. It is malpractice to leave the capsule behind, and the surgeon is obligated in removing the entire implant capsule and all of that fluid without it obviously spilling into the chest, and the total capsulectomy is required. partial capsulectomy is wrong, and the capsule cannot be left behind. This is going to be true for all 100% of the surgeons. You ask any surgeon, if a patient has BII-LCL, is capsule removal mandatory? And they all, 100% of them, they will tell you 100% of the capsule must be removed, because if any of the capsule remains behind, the cancer remains behind. So anyone who has had a diagnosis of BII-LCL, remember it's relatively rare. The BII-LCL to date, approximately like 1,250 to 1,300 cases all over the world in the history of mankind have been reported. But the FDA says it's very underreported because not everyone is checking for BII-LCL. And so it becomes mandatory. And every plastic surgeon will tell you, every board-certified plastic surgeon will tell you it is mandatory for the surgeon to remove the whole capsule, no matter how hard or how thin it is. Now, if someone has had all the capsule removed, an implant, and all inflamed tissue, the chances of developing BII-LCL essentially is non-existent. It is just like saying, because the entire inflammatory burden is then removed. Now, if you go to my private breast implant illness support group page to answer this question in a different way, there was a patient who had implants, and she had implants removed only, and the capsule was left behind. This patient, 4 years later, ended up getting BII-LCL because of the residual capsules. Very important. And I'm going to go ahead and put this paper up on my general page and also on my private breast implant illness support group page, so you can see this for yourself. So this patient had only the implant removed, capsule was left behind. 4 years later, patient ended up getting BII-LCL. This is a case report publication by another doctor clearly saying that the residual capsule caused BII-LCL. And these are not my words. These are words of another doc who put forth the paper and reported this case. And remember, if there is one, there are many others. I'm going to go ahead and answer any more questions. I am a rheumatologist and have a breast implant illness clinic. Another way to search for breast implant illness research is to look under autoimmune inflammatory syndrome in Asia. That is so true. Remember, if you go back, look in the 1990s, the rheumatologists are the next group of patients who see all these BII patients, and they manage these patients. I actually am looking forward to presenting at a rheumatology conference so that I can share my data, because that will be the most applicable subset of doctors who would listen and acknowledge and attest to the fact that BII does exist and what is very much true. So that is, quote, part of my plan, and I hope to present hopefully in the near future. I am 71 and have Dow Corning implants since 1978. Now, I will tell you, 100% chance you are ruptured till proven otherwise. Now, you can get an MRI to prove that. This is Miss Roberts. She asks, now I'll tell you, once you talk to me and we do a phone consult and I get to see what medications you're on, I get to see a note from your doctor, the history and physical exam, and if you have a good heart. Despite that, I will then make a determination if you are a candidate, but very likely, from what I'm seeing, why not? A 71-year-old patient, if she's healthy and she is basically overall in good health, certainly is a candidate. Like I said, I've operated on patients who are 75, 78. The eldest patient is 81. And remember, sometimes it's not even the age, it is the comorbidities that the patients present with that may add overall to the contraindication of surgery. So there's a patient that came in, she had liver failure. So absolutely, I said to her, I'm sorry, I cannot operate on you because you could very well bleed to death, because the bleeding profile is altered in those patients who have dysfunction of the liver. How do you know if they took out the whole capsule? Remember those 5 points I mentioned your surgeon believes in. You have the video, you have the length of the incision, the timing, and then your surgeon has a reputation that they take out the whole capsule. That gives you the sole confidence. Now, I'll tell you, in the vast majority of the world of explant surgery, that list that's floating around, or even I was included in the top 10 list, who made this list? This list is not generated by the American Board of Explant Surgeons. There is no such thing as a board. Here's someone who is smart enough to list all, quote, the big players, and then included my name, included the name of some other plastic surgeons, and then squeezed in another plastic surgeon just to get his name up there. And I'll tell you, it is wrong for someone to make those recommendations because it's a big deal to promote something where there is no expertise just so that you could earn. It is a stark law violation for someone to accept money to promote to promote a certain medical procedure or MRI or surgery where you have exchanged money for patients. This is not how medicine in the U.S. works, and this is illegal in the United States, and certainly should be illegal in the rest of the world. I have my explant next month. Now I know the specific. Now, if you go to my website, you will see what questions to ask your plastic surgeon. Now, remember, I have said nothing. I want everyone to literally fact check exactly what I have said. I have no other intention, no financial disclosures. My only intent and purpose here is to help the patients understand how I look at breast implant illness as a board-certified plastic surgeon who chose not to explant, who chose not to put in implants, and who exclusively explants. Remember, financially, it will be a lot more fruitful for me, and from a physical burden of doing the surgery itself, easier surgery, faster surgery, and less painful surgery for me to be doing implants, and that's certainly my right. I have been taught that, and I choose not to. I have no financial interest except for to help the betterment of the patients, and hopefully I'm able to translate this into practice, not only for the many plastic surgeons in the United States, Canada, but the rest of the world, like Europe, because the patients in Europe and South America and the Middle East are as human as we are, and everyone deserves the best world-class care. And essentially, as you will see, this is nothing that I'm making up. This is essentially, I'm translating what we know as the detrimental effects of breast implants and how to manage and to remove them in a very calculated, precise, pristine way, such that when we look back at every explant that I have done, I can say I could not have done a better job, and that complete pathology, microbiology workup was done, and that the patient has the peace of mind for the rest of her life that there are going to be no surprises when it comes to breast implant illness and lymphoma, amongst other things we talked about. So please read up on Dr. Clemens' paper out of the MD Anderson, extremely important. Please go to my Facebook page. Please go to my YouTube page. Hopefully you find that informative. And let me go ahead and see what other questions there are. Ask questions. Talk to the previous patients. That, if you will see it, that's the best resource you have, so there's no surprises. It certainly will help with the anxiety as well. Please share, talk about it. Hopefully we have the FDA that, bring this to the attention of the FDA, raise awareness, write about it, talk about it. You can only imagine, for me, I was looking the other way for the first many years of my career, and now I decided that this is all what I'm going to do. And I have to say, it's extremely rewarding to be doing something that the whole world disagrees with, and only with time is only going to be proven right. All one needs to do is to just listen to the patients, talk to the patients, and all the answers are there with the patients. Patients have nothing to gain except for their good health. It not only brings down the patient, but the patient's family, significant other, the work, and you will see this is a lot of hurt unnecessarily. Unfortunately, the world that we live in, where you have 17-year-olds doing Juul cigarettes, you have patients who are unfortunately smoking, who are patients doing all sorts of narcotic abuse. The system allows this, we owe it to our patients, the medical community, and hopefully, with such discussions, we're able to bring about the awareness. I'm going to have a very nice guest, and I'll end with this, Dr. Yoho, Y-O-H-O. He actually did a podcast. I did a podcast with him. I'm actually going to bring him on as a guest. He's a doctor, a surgeon in California who's now retired, 69 years of age. He has done 2,000 augmentations, and he will be my guest in the next 3 weeks or so, where you will hear from him where, God bless this gentleman's heart, where he acknowledges he did a lot of patients wrong, all 2,000. He felt that the implants were helping the patients, and now he realizes the implants only hurt the many patients that he put the implants in. We will hear directly from him. We will talk. It will be a very candid, respectful discussion such that you can learn from his experience, from my experience, and we can continue to hopefully enhance the quality of our patients' lives. Hopefully you found this informative. Please share, discuss. I have no other intended purpose but to help my many patients who come far away in a state of misery and who certainly seek the relief. I'll end with this. The many patients that come, they have all said two things. Number one, they had wished they had never gotten augmented, and they wished they had gotten explanted sooner. The implants only hurt the body. They do not belong in the body. And this is hopefully something where the FDA will step up one day and hopefully ban not only the silicone but also the saline implants. This is Dr. Khan, Executive Plastic Surgery. Thank you very much. Bye-bye.